Tonight's presentation is titled Regenerative Medicine for Soft Tissue Injuries. Before we begin, let me go over a couple of housekeeping items. First, this webinar is being hosted via Zoom and it will last about 30 to 45 minutes with a question and answer session following. To ensure the best audio for all the participants, please keep your microphones and video turned off throughout the presentation. If you have any questions during the talk, please type them into the chat and we will address them during the Q&A period at the end. I'll provide a link in the chat before we conclude where you can obtain your CME credits for today's session. We're delighted to welcome Dr. Jesse Morse, a double board certified sports medicine and family medicine doctor. Dr. Morse pioneered groundbreaking treatment protocols that combine traditional orthopedic medicine with cutting-edge regenerative and integrative approaches. He's renowned for his innovative prolotherapy technique, a comprehensive treatment philosophy that has helped countless patients achieve optimal recovery without surgery. His personalized approach combines advanced treatments like prolotherapy, PRP, and biologics therapy with integrative solutions, including hyperbaric and precision medicine. Dr. Morse's unwavering commitment to finding permanent root cause solutions rather than temporary fixes has established him as a leading voice in regenerative medicine. Before I hand over to Dr. Morse, I want to extend our gratitude to the American Academy of Stem Cell Physicians for making this webinar possible. I'm also excited to invite all of you to our upcoming meeting in Miami from March 14th through the 16th. For more information about this event, please visit www.aascpconference.miami or check the chat for more information. Please welcome Dr. Morse. Dr. Morse, the floor is yours.
Thank you very much. So, give you a little background. I did family medicine residency and then realized early on that I wanted to do sports medicine. I did my sports medicine fellowship at USF in Tampa. And then when I finished, I only wanted to do sports. And I spent a couple years in a traditional ortho practice. Then I realized that the majority of traditional sports medicine is either doing cortisone injections and gel injections or preparing people for surgery. And in most of traditional medicine is Band-Aid to basically, at least orthopedic wise, to Band-Aid people to get joint replacements in some capacity, unless you're fixing a fracture or whatnot. So I realized that that is more temporary, and I wanted to try something that was more permanent without surgery and without replacement if possible. So came down to Miami and joined the Osteopathic Center, where I've been here since 2020. And we basically use either the person's body or a donor to help optimize their tissue. The approach we take is very unique, and I'll share that with you today. We've had fantastic success. My partner, who started it, Dr. Goddard, has been doing this for about 15, 16 years and has had countless patients that never needed to have surgery. Otherwise, most people would just assume that you had to have had surgery in order to get the same level of success. So no specific financial relations to disclose. I am double board certified in both family and sports. I'm an assistant professor at UCF and in family medicine and sports medicine. I have a couple other podcasts and stuff that keep people, and I do a lot of integrative medicine and ozone and a bunch of other stuff. So the primary issue with the body in healing or lack of healing is due to poor blood flow, whether it is ligaments, tendons, because they have a very poor blood supply, whereas bones and muscles, for the most part, have a really good blood supply. So at the end of the day, if your ligaments and your tendons, think your Achilles, your rotator cuff, your ACL, if they're not getting blood supply, they're not healing. The body only heals to about 85% naturally, and eventually you just start building more and more scar tissue. So if you were to think of a grading of an injury, traditionally we think of 1, 2, 3. One would be a mild strain, quote unquote. But if you look at it under ultrasound, the architecture looks pretty similar. I specialize in ultrasound, so I use this pretty much every day in my practice. Moderate is more of a partial tear, where there is still some tissue remaining, but a significant compromise. And then severe is pretty much no longer attached to the bone, or significant compromise in the tissue. Under ultrasound, just looks like an explosion. There's not a whole lot of normalcy there. You think of it classically for muscle strain, hamstring, quadriceps, calf. You're ranging from a couple of weeks to a grade 3, which is relatively rare. It can be several months, sometimes longer, depending on the specific body part. And oftentimes the grade 3s require surgery. Tendons, on the other hand, are a little bit of a different situation. If you think of the body as being built as muscle, tendon, bone, or if it's bone, ligament, bone, that's kind of how we're built. So the ligament or tendon is basically the rate limiting factor in that specific joint. The way most people have issues, and I had someone today come in, and their shoulder is pretty banged up. They're like, once I get going, the cracking and the popping and everything starts to subside, and I can actually do my exercise. But when I'm cold, it hurts, it's stiff, it's sore. And a lot of that is because the brain is trying to protect that specific joint from further injury. So it tells those muscles, don't move. I want you to squeeze and protect. And a lot of the times that is the primary issue, because the body doesn't have the ability to restabilize and protect that joint. So it's basically telling the muscles to do that. Once you start loosening up, you can temporarily, kind of block that, whether it's through a cortisone injection, whether it's through massage or e-stim or something like that. But once the body senses instability, it's going to go back into protection mode, and it's this vicious cycle over and over again. When you think of ligaments, there's wrist, there's the ACL, there's spinal ligaments that, they're all over the body. And then when you think of tendons, you can think of tendinitis. Most people think of it in golfers, or tennis elbow, or Achilles, or rotator cuff. And then most people have probably heard of tendinopathy, which is basically a disorganization of that tendon. I like to describe it as, think of a normal tendon as like a straight highway, beautiful, nice roads. And then think of tendinopathy as these crazy kind of curvy back roads of dirt road, just very disorganized. And you can actually have calcifications and just normal normal and irregularity within those tendons and fat, so that they're no longer as strong as they used to be. Most people confuse tendinitis and tendinosis, or AKA tendinopathy. And the easiest way to differentiate them is tendinitis is an acute inflammation, whereas tendinopathy is more chronic and is not really inflammation. It's actually changes to the structure of the tissue. And you can technically have acute inflammation or acute tendinitis on chronic tendinopathy. And that's usually what most injuries are, unless they just happened. If something is acute tendinitis and you do not address it, eventually that tissue will change and become chronic tendinopathy. And then if it calms down, it might not bother you, but if it starts to flare up again, then it's going to become acute tendinitis, but now on chronic tendinopathy. In my opinion, the goal of healing, or soft tissue healing, should be to deliver growth factors to improve the quality, strength, and flexibility of the tissue, but also to prevent future injuries. Traditional medicine uses a lot of cortisone, and basically to kind of trick the brain into thinking there's no more pain, but this actually weakens cartilage. It can raise blood sugar and a bunch of other stuff, and it actually can trick the brain into thinking that the tissue is healthy. So now you start pushing through a mild injury, which eventually becomes more moderate. Whereas regenerative medicine, which is your PRP, your classic prolotherapy, any of the different stem cell lines, they deliver a series of growth factors, or MSCs or HSCs, or different stem cell or growth factor lines that can actually help support that cartilage and build and positively change that environment, which can actually permanently change the quality of that tissue. So it is no longer a temporary solution. So people ask, well, what can be injected? So I usually tell people that when I inject something, it's not a traditional injection. The shoulder gets one injection, the knee gets one injection. I do a prolotherapy based approach, which I'll talk to you about in a sec. But when I tell people, like, well, I'm going to do the same style of injection on your shoulder. The question is, what's going to be in the needle? Is it just going to be prolotherapy, which is lidocaine and dextrose? Is it going to be ozone? Is it going to be hyaluronic acid, which is traditionally only for the knee? Is it going to be a variant of plasma, PRP, PRF, PPP? Or is it going to be one of the stem cell lines, one of the growth factor lines? Your bone marrows, your adiposes, your biologics like tissue allografts and exosomes, and then a bunch of different things available now. Ideally, in my opinion, you're avoiding cortisone at all costs because it is counterproductive. So when I look at the shoulder, most people see it and say, okay, I'm just going to inject and hope that the cortisone gets everywhere and then send someone to PT. Well, the problem is most of the injuries in the shoulder are very specific to an area. There's a reason why something is not cooperating. So when you look at it from a tendon and ligament perspective, there's a lot of things to directly inject. So if you just inject one thing, there's a good chance you're missing 50, 60, 80% of that shoulder. You may address where the most pain is, but they're not actually stabilizing the entire joint, and eventually something's going to break down again. So when you look at the shoulder, I traditionally inject 10 to 15 different spots, usually under ultrasound guidance, because I want to collectively strengthen that entire joint. I almost think of it as traditionally when you're looking at an injury, if you're putting a cortisone, they're basically shooting almost like fire on a mountain, and you're sitting at the base of the mountain, and cortisone would just be shooting water from the bottom and hoping it hits it. Whereas if you're doing an ultrasound guided or prolotherapy based technique, it's almost like you're in a helicopter directly hitting those individual fires. That's kind of a more very direct approach. Whether it's ultrasound, whether it's X-ray, meaning C-arm, or sometimes guided in other means. If you look at the shoulder, which is very complicated, you almost look at it like a clock. Noon, 3 o'clock's towards the front of the armpits, kind of 6, and 9 o'clock is more posterior. So you can have slap tears, you can have different tears. So yes, you may address only noon, but the problem is the rest of those little ligaments and tendons are weak as well. They might not be as bad as where the tear is. So this type of tissue does not really respond to just PRP. It's just not strong enough, regardless of how strong your PRP is, how potent your PRP is. So in order to quote unquote fix a labrum, whether it's in the shoulder or the hip, unfortunately, you need a stem cell line. Without going a deep dive into what stem cells are, I usually basically tell patients, think of them as the ultimate traffic cop. They are delivering resources exactly to the injury and telling the body, hey, you have an injury here. Here's what you need. Go to work and fix it. Fix it as much as you can. We're not going to make this shoulder like you were 15. That's not realistic. But I can make it significantly better to the point where you have either little to no pain, you have full functionality, and potentially like it was never injured. You know, it may be 90, 95%, but that's significantly better than likely what they're dealing with now. The worse the injury, the more aggressive you have to be. When you look at this as an ultrasound, this is what I do traditionally for most of my patients. I do ultrasound guided in all my evaluations, and most of the time I inject. This was a 14-year-old baseball player that had a significant tear in his deltoid and his subscap, which is rotator cuff. And you can see this little bony changes down here. That is actually a partial tear off the bone at 14. So you kind of get a gauge that that body will never be the same after that injury, regardless of how long they live. And that's just the nature of how the body, quote unquote, heals itself. The most commonly injured rotator cuff is the supraspinatus, and that's for pretty much everything out in front or overhead. And it's not that thick, but it's used for pretty much everything we do besides kind of reaching behind you and then reaching across you like a seatbelt. And these respond really well to PRP. And sometimes if they're more partial tears or full thickness tears, then you do need more of a stem cell line if you really want to move the needle. If you look here, you can see this bone, this white right here is bone, and the top of the screen would be skin. And this is a little deltoid up here. We don't really worry about that. Look at here, you can see this white right here is very normal, pretty. This is a partial tear of that tendon, this little black kind of hole in there. And you can see over here on the right side, it has a significant tear. That's where it attaches to the bone. So if you bring that needle in and inject directly into that area, the weaker the tendon, the weaker the tissue, the more it will open up under ultrasound. So you can actually see it and do it in real time. This is a different patient, but or same patient, different view. You can see he had a partial tear over here where this white part over here is nice. This part over here is significant and tendinopathy. So you have to inject that. If you don't know what you're looking at ultrasound, you're going to be confused. This black part down here isn't a partial tear. That's actually the articular cartilage on top of the bone. Um, and you can see here that that's the needle going in, and the more beat up and kind of choppy the tendon, the more potency you're going to need, or the more oftentimes you're going to have to do it. This one is a great example of a partial tear. You can see that the tendon, any of the tendons in the body have a sheath around them. So think of that almost like that coating around a sausage that has that kind of coating. That's what a tendon sheath is. So as long as you get the needle past the sheath, you will get the product into that tendon. But ideally, you want to deliver it right to where the tear is. And I've seen tears where I injected on the left side of the screen, and it actually went all the way over to the right side of the screen because it's contained in that sheath. This one I think is a video. I'll just continue because it'll take a time. So you can see here that is a ginormous tear, very, very large tear. You can see this black part on the right side. That's a huge tear in the supraspinatus. And someone of this caliber is just going to have trouble grabbing a cup of anything off the shelf, grabbing anything out of the fridge, combing their hair. These people are miserable. But you can fix these, but you can't just put a little cortisone. You can't just put a little PRP. You need to be more aggressive. Traditionally, I have a tendency to do things in stages of 3. Day 1, I usually do more of a comprehensive combination of either any of the stem cell lines for this type of tear, and sometimes PRP. And then rounds 2 and 3, whether they're on day 3 or week 2 or whatever, will be more of a PRP. I custom build the entire injection for that specific patient. So if they have a partial tear here, a minor tear here, if they're a professional athlete versus a weekend warrior versus someone who just doesn't want to be in pain, every single syringe will have a different potency because it's going to be labeled for that specific tendon. So you're not hoping everything is a design plan. So you can kind of see the difference and levels to injections. If you're just blindly assuming that a little 5 cc's of PRP is going to move the needle, you're going to be disappointed. On average, for something like this, I'll do 24 cc's of really strong PRP, 1.5 to 1.7 million platelets per ml, and I'll do that 3 times. So you need volume, but you can fix these without surgery. You just have to know where the needle's going. You have to use really good physical therapy, and you have to use the right proper treatments. You can't just assume that a little PRP is going to be strong enough to unfortunately fix some of the bad stuff. So I'll move on. A lot of times we're doing suprascapular nerve blocks, which helps with the pain both acutely and in the long term. Sometimes there's scar tissue in there. We use a prolotherapy-based technique, which basically means you're kind of breaking up that scar tissue with the needle while you're numbing it up, and that significantly helps to heal overall, just to feel better. A lot of the times when someone has a frozen shoulder, if you've ever heard of that, it's an awful condition. You can actually see that under ultrasound if you're good at ultrasound, and you can actually break up that capsule with just fluid. Even if you just put saline in there, you can break that capsule up and actually get their shoulder to start moving better, usually with the help of a good therapist. If you go over to the hip, it's a very similar situation, obviously different body part. Most people who have bad hip pain, it's either due to one of 3 things: osteoarthritis, a labral tear, which are both usually intra-articular, or a glute medius tear. Most of the issues with the hip are internal, but there's a lot of different structures on the outside of the hip that are responsible for stability. And if you don't address those, and if you just put a joint injection into the joint, you're not going to address those, then you're never going to really get good results. And eventually you're just setting them up for a hip replacement. If you can inject the entire hip, both front, side, different part of the side as well as the back, you're giving them the best chance to succeed. Depending on the severity of the injury will depend on what product choice and potency you're going to need. We have several patients that have full thickness tears of their labrum and are playing soccer at a very, very high professional level that just took stem cells, never had labral repair surgery with significant impingement syndrome, what we call FAI. So you can do it. You just unfortunately need the right method and injection style. This is an anterior hip joint injection. Traditionally very deep, depending on the size of the person, can be 3, 4, 5 inches deep. If you look here, this is what a bad osteoarthritis of the hip looks like. So you can see that kind of red, angry bone. That's the body trying to stabilize the joint. So if you can do that with either PRP or stem cells, as well as some tissue on the outside, you can prevent that from getting worse. You might not regress it. You might not make it look like they were 15, but you can make it feel significantly better. If they present to you, already at stage 9 out of 10 or something like that, it's very hard to get them where they're pain-free. But if you have someone that is, 3 or 4, and they may be miserable, but they want to prevent becoming that 5, 6, 7, eventually needing a hip or knee replacement surgery, you can do that. It might not be a cheap option, but it is an option. Similar to the shoulder, the hip basically looks like a clock, if you think of it that way, and you have to inject pretty much most areas of the clock if you're going to be successful with a hip injection. Simply injecting just the joint is not going to be enough to really move the needle in the long term. It might buy them 6 months, but they will come back to you and say, hey, that didn't work. I had a patient that actually flew to Mexico to do their stem cells, and they only injected it in a couple different small areas. And 6 to 8 months later, he's like, it was better, but it's still not good. What can you do for me? So now we basically had to reinvent the wheel and basically inject everything because he didn't want to do it right the first time. When you look at the side of the hip, if anybody says I have hip bursitis, that is not bursitis. It's usually a partial tear or tendinopathy of the glute medius. This is the ligament or tendon on the side of the leg that's responsible for picking up your leg and rotating it, which is pretty much everything we do. If you look at this, the screen here, you can see the tendon is attached in 2 spots. You have the tendon on top here, and there's actually one on the side here. So if you don't inject both of them, you're not going to address the whole problem because they're 2 different planes, and the needle has to be in 2 different locations. You cannot hit both of them in the same plane because they're 2 different sides of the bone. You just can't get the needle to bend that far. When you inject it, if it's a partial tear, you will see that tissue open up significantly on ultrasound, and it will look like the tissue is not the same as before you started injecting. If the tissue barely changes and you just put 3 or 4 cc's in there, that's good, healthy tissue. You maybe have some scar tissue and it may not be too bad, but that tells you that overall that tissue is actually pretty good. And a lot of the times, if you don't inject both the lateral and posterior aspects of the glute of the greater trochanter, you're going to miss where the quads attach to the leg, but you may hit where the glutes attach. And this is a very important stabilizer for the lateral hip. Just kind of gives you a summary of where the different areas of injection are. Yes, for the hip, I would do anterior under ultrasound, lateral under ultrasound, as well as posterior. Usually, personally, I prefer under X-ray or C-arm, which I have one in the office, but you can do it under ultrasound. It is a very deep injection, 4 to 5 inches deep, depending on the size of the person. So doing that, quote unquote, blind is a little risky if you don't know what you're doing. But you do need to hit the posterior aspect because they're going to have scar tissue there, and the labrum can be injured there or arthritis there. Overall, I've seen a lot of what we call capsules stuck, and the capsule is basically the balloon around that hip joint. And if you do not inject into the capsule or get the needle into the capsule, you will not get issues you'll not address those issues because it's not going to magically penetrate through that capsule or bone. You really need to put the needle through there, similar to a knee. And when you see this is a very classic issue. If anybody has hip pain in their 20s or 30s in the joint, in their groin, it's traditionally due to something called FAI, which is basically an instability where the body basically starts adding bone because the hip is so unstable that that they can't function. So essentially what happens is the body starts adding extra bone, and that causes a clipping effect and eventually starting to tear the labrum. And eventually it will lead to arthritis in the hip. And then a lot of people have, hip replacements by late 30s or early 40s if they're very active. If they're not active, I've seen people in their 50s and 60s that had pretty significant FAI, but they weren't they weren't very active, so the bone didn't really need to stabilize, and they ended up, kind of making it happen. But it will lead to arthritis significantly faster than if they didn't have this. Some of it is quote unquote genetic, and some of it is just their compensation patterns. I've seen, early as 14 years old that had a bad labral tear from this. She was a horseback rider that just was kind of sitting in this very aggressive stance all the time, and she could barely lift her leg because her labrum was so torn. So think about, that at 14. This is one of my favorite cases. He was a very, very high level soccer player down here in Miami. Came in March, April. He was playing. He wanted to play in his last season, his senior season, but he didn't have time to have a labral repair in his hip because he would have missed the whole season. He just didn't have enough time to get back. So he did have FAI, like I just showed you a second ago. But when you look at it, he didn't have any cartilage defects. He had a little fluid in there, and he didn't have a whole lot of wear and tear. He's only 20, but he had a pretty significant labral tear. So this type of situation, because it is a labrum, because it's poor blood supply, you have to do a stem cell line, whether it's bone marrow, whether it's amniotic line, exosome line, whether it is adipose or a donor adipose, or, whatever it is, you need a stronger growth factor in order to really move the needle. And not only just that, you need appropriate volume. You can't just put 1 cc because most of the time it's not going to be strong enough, especially for someone that's 20 and going to be, running miles every day and kicking and playing, 4, 5, 6 days a week. So you have to be appropriately aggressive. Day one was an amniotic tissue allograft with PRP, ultrasound guided. I do a lot of high dose vitamin C with my injections, either same day or next day. It helps significantly collagen deposition, also helps with pain and inflammation. I repeated the same thing basically the following week. And then the following week after that, I did PRP by itself, which is pretty standard for my procedure dose. And I did usually high dose vitamin C in each of those days. At 6 weeks out, he had a significant range of motion, hip flexor, a little bit of pain, so a little prolo. That's a compensation pattern. Yeah, 8 weeks out, 100% range of motion, pain-free. At 2.5 months, he was cleared to return to sport. And 3 months later, he was already trying out for a professional soccer team in Africa, which is kind of crazy, but just who he was. To give you a comparison, if you had labral repair surgery, they're not cleared to play between 4 and 6 months. So he would have missed the entire season and he wouldn't have been able to do any of this. Not only did he do well, his team actually won the cup that year. And I talked to him last week or the week before. This is probably 2 years ago. Has never had any issues with that hip ever again. So overall, it can be done. You have to use the right stuff, but you put it in the right place, but you can definitely do it. Kind of gives you a little bit of an overview of where you put stuff. I'm going to continue to go to the knee, which is a very common area of injection. Most people just put their injection into the quote unquote balloon or joint, usually from an anterior approach. But most of the ligaments and tendons are actually on the outside of the balloon or the knee. So you cannot fix the inside of the knee, the outside of the knee, if you just inject the inside of the knee. You have to put the needle where the injury is. And you have to understand the tensile strength of tendons. You have to understand that there's small little ligaments and tendons, what we call patellofemoral or meniscofemoral, which are these tiny little ligaments that are responsible for holding the meniscus to the bone, for holding the kneecap to basically the patellar tendon on top of the kneecap. So if you don't address these, the scar tissue that's there or usually there will prevent things from gliding normally, and you'll have this abnormal kind of pattern of gait. If it's the lateral part of the knee, much, much more complicated. There's a lot of moving parts over there that can be injured. Is the hamstring injured? Is the IT band injured? So there's a lot of things. You can't just assume that one thing's a problem. I have a very, case that taught me a lot. Big, huge NFL lineman, 6'6", like 350, just a monster human. And he presents to me and he's like, I have knee pain and I have an MRI and it tells me I have a torn meniscus. I'm thinking about having surgery. I says, all right, well, let's see if your meniscus is your only problem. So what I do is I put a quarter lidocaine blocked the inside of the knee. If the meniscus was his only problem, 100% of his knee pain would have went away, but only half of it went away. So I said, okay, that's not all of your problem. Let's see what else is going on. So I looked on the knee on ultrasound. He had a partial tear of the quadriceps tendon, which is basically where the quad attaches to the kneecap on the top, on the lateral aspect. So I blocked that up with lidocaine, and he said, "Oh, half of the remaining pain went away, but a quarter of my original pain is still there." I said, "Okay, let's look around." So he actually ended up having a partial tear of the hamstring tendon on the opposite side or underneath the knee, which stabilizes the inferior part of the knee. So I blocked that, and I had him running up and down the hallway of my office. And he's like, all my pain is gone. I said, if you went in for the surgery and just had your meniscus trimmed and did rehab, you would have been disappointed because they only would have addressed 50% of your problems. You had 3 different injuries. The other 2 never showed up on MRI because the injury wasn't, quote unquote, severe enough to pick up on imaging, but that doesn't mean it wasn't affecting you. By lidocaine blocking him, diagnostic blocking him, that confirmed that, hey, your injury is 3 places, not just 1. So if you address all 3, all of the pain should go away and the knee should be significantly more stable. That is an easy way to confirm that the injury is exactly what you think it is, or is it more complicated? We do this a lot with hip and back because there's a lot of connection there. If you block the hip and block the hip flexors and everything, and they still have pain, okay, that tells you that the spine is also involved too. So if you just make the assumption that they're going to get an epidural, they put some stuff into the hip, all their pain is going to go away. Maybe, but maybe their problem is more than just one thing. So you do have to confirm where the pain is coming from if it's not clear cut and straightforward. The knee can be relatively complicated. I had a very fascinating case that actually got published last year. It was in January of 2023. 16-year-old travel basketball player, big kid for his size, but he accidentally landed on a bent knee on a trampoline. Now, when he initially presented to me, it was 2 years later. So this knee had healed. It was a pretty significant PCL sprain, and the PCL is basically the ligament that's responsible for stability of your knee going backwards. So basically, when he put his foot down, it was almost like his knee was hyperextending because the PCL was so loose. The problem was it healed, but it healed very loose as opposed to being tight. So what essentially happened was he couldn't play basketball because every time he would run, his knee would kind of do its own little thing. So the surgeon was like, well, there's nothing I can do. The ligament is healed. The MRI showed it was healed. So I said, well, if you inject the PCL and the surrounding structures, but predominantly the PCL, you can, quote unquote, retighten it, and you can get that PCL to tighten up again to the point where that knee is stable. I liken a PCL sprain to you sitting on a bar stool and having 2 of the 4 legs really loose. You have no idea which way that's going to move, and that's classic for a PCL. We often see it either in car accident injuries when the dashboard hits your kneecaps, or you land on a bent knee falling down to the ground. That's usually how we do it. Most of the time you don't need surgery, but sometimes that knee is never the same because it's just so loose that it just provides so much instability. So long story short, it was an isolated chronic PTL sprain. He did have a little patellar wear and tear even at the age of 16. So Mom said, I want him to play basketball. I want him to be happy. I want him to be active. Let's do something about it. So I said, unfortunately, ligaments require a little bit more than just PRP. So we ended up doing bone marrow. So I took it out of him. I do it what we call a whole bone marrow. So I take the bone marrow out of his hip and I put it directly into the body part. I do not spin it. I don't do anything to it. Sometimes I'll add PRP to it if I need more volume. So we did that on day 1. He tolerated high dose vitamin C. So yes, I did it on a 16-year-old after I checked his G6PD levels. We did a red light, infrared light, which is a biophoton, a couple of times. And then we repeated the same thing, but now just PRP. So we just took blood out, spun it down, and put it in. This was over a 10-day period. We injected the PCL, both anterior and posterior. You have to be careful with the posterior. You make sure you know what you're doing because there's a lot of blood vessels back there. We injected basically the entire knee, but also mid-ligament, posterior attachment, and anterior attachment on X-ray or C-arm guidance, and I'll show you that in a second. We did the ultrasound, under ultrasound, we did the quadriceps tendon, the patellar tendon, the patellofemoral ligaments, medial joint line, lateral joint line. He had a little Hoffa's fat pad issue and intra-articular. So, when you're putting 5 cc's of PRP or something, you have to understand where all of that can go. If you look, on day 1, I did 55 cc's of volume in a 16-year-old. And then 9 days later, I did 30 more cc's. That is what it takes to heal this stuff. You can't just put 5 or 10 cc's and expect good outcomes, because you're not going to get there, because that ligaments and tendons require more volume than you're unfortunately putting in there. So when you look at it, this is an ultrasound posterior approach for the PCL. You really have to know what you're doing, because it's a very difficult injection, but you can do it. If you look at this kind of darker piece right in the middle, that is the actual PCL attachment. This is actually one of my favorite slides because I like the colors, but this is him with 3 different needles going in through the front of his knee. Each of the needles is going to the different part of the PCL. And that's the contrast to confirm you were intra-articular. So this confirmed that, yes, I was exactly where I needed to be. Now, how did he do? I send all my patients to very aggressive physical therapy, hands-on, one-on-one, grassed-in dry needling, cupping, blood flow restriction. You need to mobilize that tissue. You need to get rid of the scar tissue. Sending them to someone who has 5 other patients at the same time is not going to get the results you're looking for. And unfortunately, most of the time, those are the insurance-based ones that are covered. They just don't pay enough to really make enough money to be one-on-one, unfortunately. So at 2.5 months out, he had full stability, no restrictions and no pain, and he was playing basketball 3 to 4 days a week, which is pretty significant. I saw his mom maybe 3 weeks ago or so. Never worried him ever again. He's probably 18 or 19 now. So overall, he did really well with just 2 rounds. Usually I do 3, but just 2 rounds. And the beauty is his bone marrow was so strong because he's only 16. He still has a ton of beautiful stem cells in there, whereas unfortunately that drops off significantly in our 20s and eventually to our 50s. Another case for his shoulder this time, a 62-year-old female, significant instability. She fell off a ladder one time in 21. She tried to catch someone that was basically falling a little bit after that, and then she slipped and tried to break her fall in 22. When you hear that, that is classic rotator cuff. Almost always when you're trying to quote-unquote break your fall, that is going to be a rotator cuff injury. Difficulty with dressing. Any women in watching can appreciate this. Can't put a coat on, can't put your bra on, can't comb, can't pick up your pants. Like, it is a nightmare. You cannot figure out how to sleep. You're moving your arm every which way, trying to figure out which way to be comfortable. It is awful. It is a very frustrating condition, and it throbs, especially when in the middle of the night, so you don't get a whole lot of sleep. Traditionally, people get cortisone injections for this. The first one helped. Unfortunately, the second one didn't. So then the question becomes, I'm 62. I don't want a shoulder replacement. I don't really want rotator cuff repair, which is 6 weeks in a sling and then 6 weeks of intensive rehab before you can really start using it. So what do I do? Well, let's look at it. Can you do PRP? Can you do, or do you need more of a stem cell line? Do you just need physical therapy? Well, when you examine her and you see that her job is abnormal and all these tests are specific for rotator cuff, you see, yeah, she's got a bunch of different things that are beat up. You get an MRI. She has a small, full-thickness tear of the supraspinatus tendon, which is pretty much everything we use in the shoulder. And she had a little, wear and tear in the bicep, but it was fine. And then she had, pretty moderate arthritis in the shoulder. So this patient did not want to use her stem cells because she's in her 60s and she's like, my stem cells are old. I want to use young, strong ones. So we did a tissue allograft and PRP on day 1. The next day we did high-dose vitamin C. The following day after that, we repeated it. Yes, very aggressive, but she wanted to be very aggressive. And then on day 4, we ended up doing high-dose vitamin C again. Her partial a partial slash full thickness tear of the rotator cuff, unfortunately required a little bit more than just PRP. She would have got better results with PRP, but she wouldn't have been back to 100% pain-free, full range of motion, no issues. And these are all the different areas I injected. I don't need to put the strong stuff in every spot, only where the severity of injury is. If you have the luxury of something like bone marrow adipose, you have a lot of volume and you can put it wherever you want. If you're getting an allograft or a tissue-based graft, it gets pricey. So you have to be selective about where you put it, unless you just have a lot of money. I got it. Rarely do I do this, but this time I did. We happen to get a follow-up MRI, and there is no longer a tear, which is pretty cool. Rarely do you see a follow-up MRI that shows a tear that was there and no longer a tear. So it shows you that, yes, it is possible. I don't remember if this is 6 months or a year later, but it was, a decent amount of time. You cannot do this in 3 months. It usually just doesn't heal that much. But overall, significantly better. It says 6 weeks. I thought it was longer than that, but that's ridiculous. But in general, I do not expect them to heal that quickly. But in general, you can do this. This is another case. This time was a 28-year-old male, pretty significant labral labral tear at 3 o'clock, which is kind of in the front of the shoulder. But he wanted to use his bone marrow because he's young and healthy. Did 36 cc's. He only was in town for 2 days, so he didn't have time to do multiple things. He lives in Texas at my clinics in Miami, but he didn't want surgery. He did a lot of CrossFit, a lot of very aggressive workouts. So we had to be very aggressive. I still see his father. His father is one of my patients, so I still see him all the time. And he did amazing. Within 3 months, he was pretty much pain-free. Within 6 months, he was back to his crazy workouts. And by a year, he was back to competing in CrossFit, which is impressive when you have a pretty significant labral tear because there's so much instability in that shoulder. He had PRP before, and it just was not enough to stabilize the shoulder, and that's pretty classic for a labral tear. One other case for the shoulder, this is actually a professional tennis player that many of you would know if you follow tennis. And this had significant right shoulder pain. This was her hitting shoulder, so she couldn't hit. She was miserable. She didn't have the velocity anymore. She couldn't reach all the way up to hit. So she had a history of cortisone injection in October 2020. In November 2020, she had another one. In December, she had another one, and PRP by a very renowned orthopedic surgeon. And then she had something called Regenerative, which is basically modified PRP. And then she actually had a subscap repair, something called a bicep tenodesis, and even labral repair. So now you're dealing with a completely different anatomy. But she still was not able to get there. And she was like, well, do I retire? I'm only 28. Do I retire? I still have a lot of potential left. I want to do something. So this is one of those cases where we had to basically, quote unquote, prove it to the patient that we can actually help. And unfortunately, sometimes it comes down to that. So we did a diagnostic lidocaine to each of the areas where we knew her injuries were. And then within about 5 minutes of doing the diagnostic lido, she could pretty much have full range of motion and had zero restrictions on her, quote unquote, serve. And she was like, wow, like that's insane. I said, yes, we basically just turned off your brain into thinking that there was an injury. Yes, you still have an injury. We just told it you don't for a couple minutes or an hour or two. But that shows you that if you put the needle in the right spot and put the right stuff in there, you can actually address this. So she had a pretty significant labral tear. Anterior, superior, and posterior capsule were all injected, as well as the labrum itself. Supraspinatus, infraspinatus, a couple other areas. And she did amazing. She did a combination of bone marrow from her and a little bit of tissue allograft in a couple of the specific areas where she wanted to be really aggressive. And mind you, bone marrow is very, very inflammatory. So 6 to 8 weeks, most of the time, they cannot do a whole lot, especially in a caliber of athlete like this. We did not use a whole lot of tissue allograft. That's 2 cc is a very small amount for a labral tear. A lot of times I'm using 6, 8, or 10. So that's where the bone marrow was able to substitute. The crazy part is that 6 weeks out, she had no pain. She had full range of motion. Her strength was coming back. And at 2.5 months, she was back to playing live professional tennis, which is, pretty cool. At a year out, she no longer had any issues with the shoulder at all. She ended up having knee issues, unfortunately. And then I talked to her maybe 6 months ago or so, and she still has not had any issues. And it's probably been almost 3 years now. So this stuff does. I have a physical therapist that we refers to us a lot, that's in Miami Beach, and he had his shoulder injected in 2017 with a labral tear, and he still has had no issues with it, and that was with bone marrow. So this stuff does last if you have the right volume, if you have the right diagnosis, if you use good therapy, and you know where you're putting it. Overall, just works out really well with this type of stuff. I'm going to continue with a little bit more and just kind of give you, because I think we're wrapping up. It's 8:48, so I think we're wrapping up. This is a modified version of what I will present at the AASCP conference in March. So if you're interested, I would recommend you come to see that among the other amazing lecturers. But this kind of gives you an idea that yes, you can treat and quote unquote fix, I don't like the term heal, but fix things if you have the right diagnosis, if you understand the compensation patterns, if you put the right potency in the right volume, but also get them to the right therapist.
Excellent talk. I really enjoyed that, Dr. Morse.
Thank you.
What kind of questions do we have for him tonight? There was a question about how you administer the vitamin C.
That is IV. You can do oral, but you're not going to get to the same level in the vein, in the body. You get to about 10 to 15 milligrams per deciliter, and that's about it. When you get to when you start doing IV over 15 grams, usually I do 50, but then you can get up to 50, 75. I've seen over 100 milligrams per deciliter, usually in our cancer patients, when you do IV. I prefer sodium ascorbate over ascorbic acid only because it's friendlier. But in general, both of them work as long as they can handle it. It will give you a pretty bad detox reaction if you have other things going on. But it works really well, great for the skin, great for the immune system, and great for healing because collagen is the main thing that makes up ligaments and tendons, and collagen depends on vitamin C to be built. So you kind of flood the system with vitamin C, and you can significantly improve not only their pain after injection, but also the healing response.
Excellent. Are there any other questions? Well, I tell you, it was a nice, thorough talk. And so sometimes you answer the questions as you're moving through the presentation. So at any rate, that brings us to the end of our question and answer session. Again, a big thank you to Dr. Morse for sharing his expertise with us today. And thank you all for your participation. As a reminder, don't forget about our upcoming meeting from March 14th through the 16th in Miami. You can find the details at www.aascpconference.miami. Thank you all for attending, and we hope you found this webinar valuable. Have a great evening. Thank you.
Thank you.
Thank you
There
very
are
much.
some other questions on the chat in case that you want to answer them, Dr. Morse.
Sure. Yes. So I will
I
start with.
apologize.
Let me see here. Okay. Is there a role for fenestration of ligaments with orthobiologic flexion? Yes. Most of the time, even with just fenestration or what I call barbitage with the needle tip, you can break up, usually with a little Lido, you can put a little dextrose in there, about 15 to 20%. You can help kind of bring that back together. If you have significant laxity, you're going to probably need a stem cell line or at least a PRP line to make more progress. But even just breaking up that scar tissue and bringing blood flow to the area, a red light therapy, a PEMF, things like this can significantly help with laxity and just ligaments and tendons in general. Unfortunately, these are not covered by insurance. It'd be nice. I've had a couple international insurances cover these, but that's pretty rare. The high dose vitamin C is 50 grams. I prefer to do it if patients are willing to do it. I think it's like $225 at my office, $225. So it's not super crazy, but it's not free. It's not cheap, but it does seem to kind of help. We've been doing it for about 3-4 years now, so we've had pretty good luck with it. Is there any conditions where injection should be avoided? Good question. I avoid all autografts, meaning bone marrow or adipose or even PRP, if they have a history of cancer within the past 5 years, because I don't obviously want things moving from point A to point B. If they do not want to be inflamed, if they do not want to be in pain, if they're a professional athlete and they have to play in 3-4 days or a week or 2 weeks, then the problem is, your other issues. Excuse me, the stuff coming out of you is very inflammatory. It kind of creates a little chaos before you start the healing cascade, which takes about 2 weeks. So the issue is you can't really use it on them. It's very difficult because they're just not going to be healthy enough to do it, to return that quickly. So those people, you kind of almost have to do an allograft if you want them to return that quickly. For the people that have money, quote unquote, most of them prefer to do all allografts because the recovery is so much easier. I usually tell people I will present 3 plans to you. All 3 will work. The difference between plan 1 and plan 3 is a combination of inflammation, where the source of the stem cells is coming from, and cost. At 1 year, you won't be able to tell which one I did. Getting to that year, you'll be able to tell how much inflamed and how inflamed you were between now and then. I've had people with, 2-3 days later, they didn't even have pain from the injection, and they didn't have it after that. I've had people that even at 6 weeks, they're still inflamed from bone marrow. So a lot of the times you have to weigh all these different factors. I have a lot of people ask me, hey, is there someone that you recommend in this state or something like that? And it's very difficult to do that, unfortunately, because it's almost like trying to say, can you recommend a good mechanic in my state? It's like, well, unless you know how the mechanic works and if they fix your car and you have confidence in them, it's very hard for me to say, well, this person is very good. I know a couple people around the country who kind of inject like we do, but unfortunately this is very niche, so there's not many of us that actually do this. So most people unfortunately end up flying to one of our offices. I am from Massachusetts, so unfortunately I'm not there, but the most north we are right now is in Knoxville. Unfortunately, we don't have offices everywhere just because we can't be everywhere. Platelet lysate, we dabble with it every once in a while, but I don't use it a whole lot because it's just complicated, and I feel like I have stronger stuff that is less inflammatory. It may be a little bit more costly, but I've had better luck with it. But platelet lysate is a good product if you're using it. Do you approach chronic inflammation of the anterior tibia? Tibialis. So most of the times this is going to be an injury to the tendon or a nerve entrapment. So you kind of have to go back and figure out where the issue is. Sometimes even hydrodissect or hydrodissect that area, block that specific nerve, look at it under ultrasound, and even do a little prolo or a little lidocaine to see if you can get the pain to go away and confirm the injury. Sometimes you need imaging, more imaging, sometimes you don't. For PRP, I use a kit by EMCYTE, EMCYTE, very, very, very potent kit. It's pretty much the strongest one I've been able to find. Traditionally, PRP is measured by platelets per ml. Ideally, when they're spun down and ready to be re-injected, it should be over 1 million platelets per ml. That's kind of the gold standard, or roughly 5x your platelet baseline. With EMCYTE, the kit I personally use, we've been using for probably 10 years, that gets to 7 to 9x. So it is really potent. And I do kind of what I call manipulate or play with my PRP depending on level of potency, if I'm doing hair or face or body part. So the ones for the joints, I want it really inflammatory. I'll take a little bit of that buffy coat or a little bit of red blood cells. Stuff for the hair and for the face, I don't want any red blood cells because it's very inflammatory. It's a double spin technique I use. And then sometimes I will put it in a red light, and sometimes I'll even use the PPP to actually turn it from a liquid to a gel. And it's almost like a hyaluronic acid naturally made from the poor platelet plasma, which is nice. And you can do it usually for knee. It doesn't really do a whole lot better than that. For aftercare for following injections, to be honest with you, the patients walk out the same way they walk in. They might need a wheelchair to get to the car if it's a knee or hip or something like that, or a foot. But most of my patients, I tell them, as long as it's not bone marrow, they can pretty much shower the same day. They might not want to, but they can. I tell them to get into PT within 2 to 3 days if they can tolerate it. And I usually coordinate directly with the physical therapist to say, hey, and this is important, I want you to address compensation patterns first. That's the most important thing. Second thing, I want you to address instability and muscle balancing. And third, I want you to muscle strengthen. Do not jump to muscle strengthening because you will not correct the compensation patterns, and you will eventually have the issue over again. That's my approach. Hyperbaric medicine, yes, it works well. You can use with this. There actually happens to be a hyperbaric chamber, big, huge chamber suite in the first floor of my building. So if they want it, we end up sending them there and getting a couple sessions or a package of 10 or whatever they want to do. Usually it works better after, but it's not going to hurt them. It may not be enough before to fix the problem. I usually have better luck when you address the injury directly, and then you end up doing hyperbaric after to kind of force oxygen and pressure into that tissue. And Patrick, yes, we have analyzed it before. I don't do it on everyone just because it's time consuming. But yes, you can. The machine to analyze it is very, very expensive. But yes, you can do that, and it is overall worth your time if you have the luxury of being able to afford it. But yes, it can be very helpful. But it is time consuming. You lose a little product. But when you consistently see the potency continue to be 1.2, 1.5, 1.7 million platelets per ml on different patients, then you just say yes, this is a good product. And to give you an idea, for every 50 cc's of blood, I add 10 cc's of anticoagulant, which is usually sodium based product, and then I will get 12 cc's of potency out of that. So it is a lot of volume. I usually do 24 cc's of PRP for most of my big joints. I've done as much as 100 in one day, and they've done fine. Yes, it's crazy, but it works, and they'll make that blood again. I'm not overly worried, but overall they do well. I think that's everything.
Thank you, Dr. Morse. Look forward to seeing you next month.
Thank you very much for having me. Everyone have a nice night.
You too. Thanks.
Thank you very much,
Thank you
Dr.
very
Morse.
much.
Have a great night, everyone.